right, so y'all have had most of the ER medicine lectures, I guess. My belly hurts, chest pain, all that kind of stuff. Well, now, gonna get into the, I guess, excitement of the ER, right? So basically, trauma, it's kind of intuitive type medicine, you know, it's nothing that, you know, someone comes in and you look at them like that don't look right, well, it don't look right. It is a surgical disease, right? This isn't medicine, this is all surgical, okay? There's some underlying things that you got to think about for medicine, but to truly fix a trauma candidate requires all surgeries, okay? General surgeons are usually the most called upon, you know, for bellies. Sometimes you have cardiothoracic, which we're going to get into today. Neurosurgery for any cranial type aspects. Orthopedics, obviously, for all the fractures and stuff that you'll see from there. Today we're going to be doing thoracic trauma and going over all the details from there, okay? So our objectives for today will be understanding general thoracic anatomy. Hopefully y'all still have that in your minds and stuff and remember what's going on. Identification of life-threatening thoracic conditions that require immediate intervention. Okay? Sometimes they're not as obvious, but can be detrimental if missed. So for the most part, we'll talk about what you need to be looking for and when do you get that almighty thoracotomy and putting your hands in someone's chest and grabbing their heart. Right? That's what everybody wants to do. Y'all had ACLS recently? Well, ATLS is Adult Trauma Life Support, right? This actually was made up of a orthopedic surgeon came up with this. He had a plane crash many years ago, got taken to a rural ER in, I think, Nebraska somewhere. And of course they fumbled around and weren't doing the appropriate things, and he's like, man, I could have done a better job than this, take care of myself. And so he kind of came up with guidelines of what to follow, and this is what you're going to see, and this is from the trauma centers and surgical disciplines that kind of came up with these guidelines, and we'll kind of go over some of them. Complications associated with thoracic interventions and stuff. When you go poking around someone's chest, there's always complications that can also arise, right? Thoracic trauma is a significant cause in morbidity and mortality, especially if significant, right? You know, there are multiple things that can come on with it to be causing. The mortality rate can climb up as far as 17% of people with like blunt trauma, penetrating trauma. Those are the two distinctions that we'll have. But the morbidity escalates very quickly. People who've been in significant trauma that are sickly and sitting and not moving, you know, they can get all kinds of stuff, infections and things of that, and that's why pneumonias, the atelectasis, the empyemas, those are significant things that you have to watch, not only after the initial accident, but further down the line. And if not taking close appearance of it, they can get sick on you quick. 20% probably of what you'll see in trauma will be admitted, whether it be the thoracic or the head or the belly or stuff. They do require watching just to make sure that these secondary morbidity type things that aren't going to accumulate are going to kill them. Okay? Blunt trauma is less than 10% surgical, right? Unless it's a very significant blunt trauma where they're just smashed into the side of the wall of the car or hit the steering wheel, or most of them really don't have their seat belts on, but sometimes seat belts cause problems and things of that nature. Most of these don't really require surgical intervention. Some may. Typically those of what we call hematomas or hemathoraces. Obviously penetrating trauma has a higher degree of intervention, right? I mean, it just makes sense. You know, you got something got stuck in your chest, you have to go look at stuff. Make sense? So our points of discussion for the thoracic cavity, basically rib fractures, highly likely, you know, painful, boogers. They can cause a lot of problems for you though, okay? And depending on how many you have and where they're located and things of that nature. Pulmonary contusion, that's a big one, okay? That can be a bad problem for you, especially on how dynamic that can be. And we'll talk about some therapies with that, and especially some special ventilation type problems that we can go through with it. Pneumothoraces, everybody knows, drop lung, you know, chest tube, sticking one in, getting ready to do all that kind of stuff. Hemothoraces, same thing. Penetrating traumas, you know, sticking in the heart, things of that nature, getting into a lung. Thoracotomies, when to do it, usually during penetrating traumas. And then, you know, just resuscitative type measurements and the ability to do thoracotomy and what to do with it. Chest wall, y'all remember the bony aspects of it, the ribs, the spine, sternum, the clavicles, right? Scapulas, the muscular support, all that being part of the chest wall. The interthoracic type things is what we're going to get into a lot on some of these things, especially the tracheobronchial tree, the lungs, the esophagus, the heart, and the great vessels that sit in the middle of the chest, how these correlate to certain things in trauma, thoracoabdominal considerations. Remember, the liver and the spleen sit up underneath the rib cage, right? The diaphragm, diaphragmatic herniation, big thing, all right? These are all things that you'll have to consider when looking at the thorax. Just the anatomy of it and how the overlays look, where the ribs are over the spleen and liver are significant, especially if you're doing a thoracentesis. You know, you can't go too low and stick the needle into the liver or spleen. They really consider bad form. The heart and the great vessels, those are the big things. Y'all had radiology? Have y'all seen the widened mediastinum? Those are very significant things, okay? Can be overlooked quickly too when you're just kind of scanning things. X-rays are one of the first things that can be obtained in a patient, but a widened mediastinum is a medical emergency. That's a bad problem with the aorta, right? Have y'all discussed fast exams? Have y'all had any of that kind of stuff?
Not yet, that's this week.
This week?
Actually, it's this afternoon. Yes.
One of the quick, easiest tools that we have in the ER and to really assess a bad patient is what we call fast exams. Basically taking an ultrasound machine, rubbing gel on somebody, and looking at key points of the body. We can see if they've got free fluid in the belly, free fluid in the chest, what's going on to see, you know, hemodynamically if this patient's stable or unstable. Very quick, easy tool. I guess you'll go over it this afternoon, but very, very good tool to use, especially, you know, for thoracic type considerations. Do you have a pericardial effusion that's from bleeding? Okay? Do you need to decompress the pericardium before you go into tamponade? That's a bad problem. Do you have hemothoraces? Do you have pneumothoraces? Things of that nature. Those are ribs. Heart and lungs. All right, so let's talk about some rib fractures. Okay? Anybody ever have a rib fracture? You don't ever want one. They hurt like hell. Problem with rib fractures is the splitting of breathing, right? People don't want to take deep breaths all the time, okay? When you don't breathe deeply, you get atelectasis. That leads to collapsing of the lungs and the possibility of infection. The more lungs you have, or the more ribs that you have fractured, the worse it can be, okay? Anybody ever heard of the flail chest? Okay. Definition of the flail chest is, you know, how many rib fractures you have, usually 3 consecutive ribs with 2 contiguous spots, right? Affects the lungs and the chest wall mechanisms in which and how you can breathe and get paradoxal breathing, all right? Some of the rib fractures can cause problems, especially if they're worse or bad enough. One of the ribs can actually stick in and hit the lung, right? Not a good thing. Lung lacerations are bad, right? Sometimes bleeding from the intercostal arteries, veins, cause hemothoraces. Okay? You get contusions to the lung if you have enough trauma that breaks the ribs and goes and transcends into the lung itself. Prolonged morbidity with this is just a chronic pain and people don't want to breathe. And usually get some respiratory insufficiencies from this and complications that come down the line from it. We'll talk about, trying to reduce that amount of chronic pain. But the one thing that I'll reiterate is that thoracotomies and chest tubes are some of the most painful procedures that you will see done in an ER, by far. And even long after that you've done them, people still reap the repercussions of it because they hurt like hell. And for whatever reason, the thoracic, intercostal muscles, nerves, and all that kind of stuff are very, very painful. Even people who've had rib fractures still have those. There are occasional candidates for surgical repair, and we'll talk about stabilization of fractures and what it does for patients long term. Yeah, that's a couple of rib fractures down. What is that? 67th ribs on the lateral aspects of it. Looks like he's already had a previous fracture there at 8. So, flail chest, that's significant trauma that's been pushed into the chest itself that cause an erratic form of pressure to a rib to make it shatter in 2 different places. It's very hard to do. Thoracic cavity, sternum, and ribs and spine are pretty rigid mechanisms of guarding the thoracic cavity and can take a lot of trauma. But when you start to get these flail chests, they are significant because the amount of trauma that it takes is significant. And I also will add that it takes a great amount of force to fracture ribs 1 through 4 versus the rest of the ribs. And if you've got rib fractures in 1 and 4, that patient has had a hell of a trauma to it. And more than likely, you're going to find out that you're not going to do much with the thoracic cavity outside to take care of all the other problems that the patient's having, because they're going to have other multiple problems going on, probably abdominal and damn sure probably orthopedic. Hyperventilation is one of the bigger things. Paradoxal breathing motions, remember, breathing is a symmetrical thing that is caused by contraction of the diaphragm, pulling the lungs down, intercostal muscles contracting, moving out, expanding the chest wall. You don't have that functionality now that you have a flail chest, right? You actually can see a difference in the level of the chest and how one expands and one doesn't, and you get this paradoxal breathing. With that paradoxal breathing, you get almost a ventilation mismatch sometimes with it, kind of like with the PE. You can get contusion to the lung underneath to where that flail chest is, and again, pushing on a more discrepancy of a ventilation mismatch, which is very hard to overcome. That is a bad, bad problem. Here you can see on the right side of his chest how it's further collapsed down versus the left side. That's kind of an extreme look at it, but not uncommon in the flail chest. Usually you can push your hand up on it, you can feel the crepitations of the ribs. If the patient's unconscious, you know, you can feel that crepitation. If he's awake, he'll be jumping off the bed, down there hitting you. Sub-Q emphysema. Anybody ever seen that or felt that? It does feel like Rice Krispies. Chest X-rays, there's subtle hints of sub-Q emphysema. It's a good indication, you know, there's a problem with the lung as well as with the rib fractures and stuff. You know, that would require probably a chest tube. This X-ray is not, I mean, I keep looking at this thing, but you really can't get the dynamic of it. But you can see that you can get smoothness of the ribs are coming down, and they're just kind of disrupted there. The thing that would bring my eye to that area is basically, you see all that darkness to the outside of it, and up and down on the lateral aspects of it. So all this stuff right here, this is sub-Q emphysema. That would probably bring my eye to this area looking at it. You can see though that he's fractured through here. You're really not seeing anything back here, but in the back aspects of it back there, there's other fractures. The other thing about it is that this lining areas of it, it's pulmonary contusion as well. So you know, this guy's probably gonna have some issues and stuff and be in the hospital a while, but it's kind of hard to really see most of those. But that sub-Q would be the biggest thing that I would see that draws my attention to that area. The NTDB, that's the National Trauma Database. They review a lot of things and looking at rib fractures and associated to what goes on, but the mortality, as you would expect, the greater the problem of trauma and the greater number of ribs there are, is the severity of the intrathoracic injury, right? Like I said, this isn't rocket science. I mean, you know, if someone gets hit 50 miles an hour, they're probably going to have more problems than someone who gets hit 5 miles an hour, right? So, you know, so the more rib fractures that you have and the injury to the ribs, the severity of the thoracic injury, presence of extrathoracic injuries, head, arms, legs, things of that nature, okay? Obviously, the advanced aged can have greater problems than like a 12-year-old, okay? Osteoporosis takes a bent, you know, ribs can fracture, they're just more frail than anything else, okay? I always like this last one. The presence of 5 or more rib fractures, the mortality rate per rib is up to 3.2, right? So, I mean, 5 or more, yeah, significant trauma, right? You're going to be looking at a multitude of things. What's going on with this patient? You know, you're going to be scanning them left and right. They're going to get radiated like hell, and you're going to see what you need to put your finger in and stop the bleeding. Yeah, and that kind of goes for itself, right? The number of rib fractures correlate directly to increasing pulmonary morbidity and mortality. The more rib fractures there are, the possibility of this will go up, right? And those are secondary causes of infection, right? Lacerations, pneumothoraces, bleeding out, and all that kind of stuff. The unrelated to the rib fractures, obviously, you know, that could be due to the pulmonary contusion, aortic dissection. It could be due to other bleeding causes from the abdomen, intracranial bleeding, things of that nature. It's just saying, obviously, kind of, again, the no-nonsense of, I think my mentality of how I describe this is basically surgical mentality, right? If they can't cut or sew it, then they, you know, oh yeah, if you've got more of that, that's bad, right? But in medicine, you really have to think. Surgeons don't really think much. No one wants to go into surgery, do they? So where are we now with treating rib fractures? You know, simple rib fractures, we really don't do much. Give them some oral analgesics, although nowadays in this state it's becoming more of a pain in the ass. Have y'all gone over the new opioid laws?
That's coming tomorrow.
That's a huge pain in the ass. There's documentation you got to put in a chart about that damn long. It's ridiculous. But anyway, so respiratory support, obviously, you know, some of them may require advanced ventilation type problems versus just simple, you know, respiratory support, just analgesia to make sure they can breathe and expand their lungs without any problems. Resuscitation sometimes can be a part of what's going on with it, but those are usually in the advanced cases of which, you know, flail chest, you know, do you need to do fixation of it? Do you need to get a chest tube in it? Pain management is going to be the major key. And there are actually sometimes that we do epidurals on these patients, or doing spinal blocks to prevent the pain. That's actually some of the best method of pain management that you can do. Paravertebral. I don't know if you've ever seen these lidocaine drips that they can put on nerves and things of that nature. Can almost be as effective as a spinal block. Mobilization. There are some new techniques in which they can go in and actually fixate the rib fractures and immobilize them from moving, which reduces a significant amount of pain and actually shows early transition of the patient getting out of the hospital without less problems. Underlying conditions, injuries and things, again, from the lungs, you know, hemothoraces, all that kind of stuff that could be there. Our non-ventilator guidelines, again, optimizations of pain management is going to be the ideal type problems with this. Epidural, especially for those that really have a significant amount of pain with fractures, typically tends to be the best. If there are no contraindications to having an epidural placed, okay? Those that are sickly, those that have hypertension, those that can't go those protocols of an epidural. Again, paravertebral analgesia is very good and almost as effective as epidural. And the good thing about that is that, you know, if someone's unconscious, you can give these things without them having to be awake to take medications. Physiotherapy. Yeah, I put that in there. You can do the physiotherapy itself, but I think the management of doing and making sure that they're getting their secretions and everything out and not staying within is significant. Some of the medications can be effective of this. Honestly, I don't really in true life see much physiotherapy being done to trauma patients. That self-acting multidisciplinary protocols, these are just things that the hospital has in place to getting patients breathing without difficulties of trying to ventilate them. And those, there are structures there for trauma patients. It's just hard to say, you know, what those protocols are. They change for every hospital. That would just be a protocol type things that are based in the hospital itself. Diuretics, hemostatic fluid overload, you know, that can happen. People bleed or have significant hemorrhaging and stuff. They lose oncotic pressures, right? So when you're giving them crystalloid to keep their pressures up, you know, some of the places it's going to spill is into the chest. Okay? Diuresing them and getting fluids off of them are always a dynamic type problem of it. Hopefully they're not renal failure by then. You know, with trauma patients, you know, the bigger things, especially with renal failure, You know what a cause of renal failure would be for trauma patients?
Is it rapid?
Rhabdo, right? Significant muscle destruction releases out the myoglobin. Myoglobin is not like kidneys. They go in there and destroy the glomeruli. Okay? You add on top of that hypertension and you get ATN, tubular necrosis on top of that. People, they go into renal failure very quickly, and then, those are other considerations of why people expire. Again, they're just telling you paravertebral anesthesia, equivalent to epidural. Certain situations when epidurals is contraindicated, right? Obviously, the hypertensive patients, the ones that are infected, the ones that are having problems that can't be stabilized, that you can do the procedure on. Anybody ever seen CPAP or BiPAPs? Probably the greatest intervention tool that ever come along. I could not stress enough importance of learning about these machines. These damn things work tremendously. I've seen heart failure patients come in. I have seen asthmatic patients come in, COPD patients come in, and I've kept them from eating the ET tube just by the intervention of these things. Okay? These non-invasive type machines do a great job of keeping these patients from needing ventilation. Okay? If you ever intubate a patient, you would definitely understand the value of these, especially in trauma patients. They're not always easy to intubate, especially if they need intubation. If they've got blood in the airway or, trauma to the face, going down and what you see in a normal type thing, and, anesthesia, they have a preen condition, right? Patient's easy, they got it, they can do it. In a rapid situation, that ain't always the case. And intubations can be bad. And when you put the RSI to a patient, y'all know what rapid sequence intubation is? So when you go to intubate, which can happen quite frequently in the ER, there is a certain protocols that you follow, and they're called rapid sequence intubation drugs, okay? You're going to give a paralytic, okay? You're going to paralyze them. What is the reason we always paralyze the patient? Anybody? We paralyze the patient because we don't want them vomiting. Right? They vomit and aspirate, and now you're just more in a world of shit. And I mean it. They get that stuff in their lungs, you're going to have all kinds of problems down the line, and if they get ARDS out of that, that patient now has an 80% chance of death, just off of getting ARDS. So you're going to paralyze the patient, you're going to knock that patient out, right? Y'all wouldn't want to be awake when someone's down there sticking a tube in you. So you're going to give basically ketamine, propofol, all these other drugs that are basically going to wipe the patient out and then, paralyze them. So these rapid sequence intubations, you miss getting the tube in the first time, you just increase the risk 20% of that patient dying on you. Go back again, miss again, you're over 50%. It is not fun to sit there and trying to screw around trying to get an intubation done and you can't get it done, especially after you paralyze them. Okay? Now there are things that they don't teach it in ACLS because they just kind of skim over the intubation type process. But there are oral airways and things that you can do that you don't always have to have an ET tube in place. And hopefully you have them around. I can tell you I've been in codes in major hospitals in this area which I didn't have anything available. You know, the next thing is surgical procedure in which you do a trach or crike. It's not a fun situation, but anyways, CPAP and BiPAP can avoid that for you very easily. And all that does is just strapping a mask onto a patient and then boom, they're getting oxygenated. They put in positive pressures into the airs, expand the lungs, do everything you need to do, and you don't even have to do hardly anything. Then you don't even have to worry about ventilation, right? You don't have to worry about giving 1,000 tidal volume and blow out their lungs, right? But if you do intubate somebody, you can always give that PEEP, right? Positive expiratory end pressure. That's always a good thing. That high frequency oscillation ventilation, that's pretty impressive. Especially when oscillating the patient around. Those, and I'm kind of happy to say this, I'm glad I don't have to be a part of that. That's going to be a pulmonologist that's doing that. That's going to be hospital based. But if you ever see it, it's pretty impressive. But those, when you're getting to that stage for ventilation on somebody, that's a significant trauma patient that's probably got other problems that are going on. Independent lung ventilation, that's impressive as well. Y'all will never do it. But pulmonary goes down there, scopes them, just brings the tube all the way down there and puts it in the right main or left main, and ends up ventilating. This is significant for people with ventilation mismatch problems. People with a severe enough lung contusion that whites out one lung, well, you're not moving any air there. You might as well get the best possibility that you can get out of one lung. Okay? And that's a problem patient, obviously. I mean, that's not rocket science there. Yeah, he's not in a freak show. He's they're stabilizing fractures, especially flail chest. Those were the old days of doing it. Don't you miss living in the 1920s? You know, expand the chest out to normal aspects and then you get to breathing normal. Jesus Christ. These are the newer traditional approaches, which is much better in today's medicine. Obviously, you can see that stabilizing rib fractures with these little plate screws would be much better than sticking rods in your chest and stringing you from a pole above your bed. It's a flail chest, significant flail chest. That is a massive injury. That there would probably be, before the intervention of these things, in the hospital a good 2-3 weeks and having problems. Just by doing that reduces the hospital stay. Morbidity and mortality, lung function, or empyemas and things of that nature. Just because they can breathe without significant pain, because everything's stabilized. These plates are quite impressive. That's an impressive surgery.
Do you guys take the plates out, or do they live with them in Venezuela?
Live with them in Venezuela. Not too many people want to go back in and take them back out just because of the complications that can arise out of it. I mean, if they've gotten through it and everything's good, they can live with that and the functionality of it. Just like in spinal surgery. Someone gets fused. Like say you do a lumbar fusion. So for when you do a lumbar fusion, you're trying to get bone to grow across 2 vertebrae, right? So what they'll go in and do is put screws and rods in, right? The screws and rods, what their purpose of is an artificial fixation. So you fuse them at the time of surgery. Well, that's not going to last, because with the pressure of the body, what it's doing will wiggle, those screws will wiggle out and become loose, right? So what you do in time is have a piece of bone that's in between the vertebral discs, they fuse together, and then the screws and rods are no longer needed. Okay? When that happens, no one ever goes back in and takes those out just because of increased risk of infection problems. Kind of the same way that we have here. Plus, anytime that you put a foreign object in a body, you know they get endothelialized, right? The body forms a shell of lining over it and closes it off, and it's just a pain in the ass to get it. Limited studies, on rib fixations, but they've gone back and done retrospective type evaluation and analysis on people in the hospital. But, I mean, the data don't lie. I mean, all these are the studies. But you can see chest infections, ventilation days, ICU days, and hospital days are greatly reduced for patients who have significant traumas and rib fractures and fixation of it. The non-operative management patients do not do as well, and the morbidity mortality rates actually kind of increase with it. Again, just another way of saying what I just said, in case you don't like monitoring. Operative rib fixation, bias, it tends to be more prudent to get a patient out. I mean, I wouldn't sit there and just kind of hesitate on doing surgery on these people. Long-term effects for them are so much better than not doing it for them, But not every patient is a good candidate for it. Granny at 80 years old, man, she just had this major trauma, and she barely do it. Are her bones good enough to actually have those things put in and stabilize? She's already had a good life, what the hell? Just kidding with that. But, I mean, some patients, they just can't get it. It just, you're not going to be able to see it. They are avoided in polytrauma patients, just meaning that, if someone is just messed up, there's no reason to be putting them into another surgery and doing more things to the body and things of that nature just to fix a rib fracture. There are more other important things that need to be done versus trying to do that. And it just escalates the problem even more by further going on. Just because you can do it doesn't mean you should do it. So again, I reiterate, don't ask a surgeon if you need surgery. Pulmonary contusions. These are significant problems in thoracic trauma. When someone has a pulmonary contusion, they have had significant traumas and usually have some other orthopedic or cranial or abdominal type problems that are going on as well. But for this purpose of thoracic type things, the biggest problem it's going to provide to you is breathing and oxygenation of that patient. You're not going to be able to get oxygenation very well just because of the perfusion mismatch. Shunting of blood and moving it around in the lungs are never a good thing. That's why pulmonary emboli are so deadly in what they cause. Trying to get that managed can be very difficult at times. Can be done, but can be difficult. The other things that the lungs do is a big source of things for immunological responses and stuff, but you can get SIRS, which affects the entire body, right? This inflammatory response that goes on. Sorry. Can affect the entire body. You can get into a significant inflammatory response and then can set off a whole trauma thing of certain things. DIC is definitely a problem. Have y'all ever seen DIC? It's a bad thing. Again, ARDS, is a significant problem, especially if this SIRS is bad enough, and then all of a sudden you just get this overwhelming response, an inflammatory response in the lungs, where you get all this edema. You can have it, I mean, literally have a chest x-ray that shows just minimal disease. 5 minutes later, after having problems, you look at their lungs and they're whited out. Okay? Ours comes with an 80% chance of mortality. It is very significant. It is a problem. You know, these contusions can start to show up and being more problem over days than anything. Pulmonary PT and hygiene are essential to keep infection down, keeping pneumonias out of the lungs. The PEEP and CPAP are very good at helping expand and keeping the alveolar open and not causing much problems. Judicious use of IV fluids is very significant here, just to keep the patient hydrated, but also giving them pressure support, as well as keeping the patient moving fluid throughout the lungs and kind of washing them out. So these are pictures. That top left is basically a CT that is done to show pulmonary contusions. It's obviously bilaterally. In the posterior aspects of the lung, that are typically about, just because of where the heart is located on the skin, I would say about mid-lung. That top right one, I don't know if that's a rib fracture or not, but obviously, you know, you've got an entirely whited out right lung. Just off the chest x-ray and stuff, you'd want to know, is that really hemothoraces versus pulmonary contusion? Because you really can't tell off of that. The CAT scan otherwise shows a very bad problem of a pulmonary contusion. The lower left, there's a little bit of contusion to it. I don't see any pneumothoraces to it. A little bit of a contusion to it, but not as severe as the others. Pneumothoraces, basically a collection of air between the lung and the chest wall, right? Very common amongst all trauma patients, greater than 20% kind of show with prevalence to thoracic trauma. The different types, as we'll talk about, are basically a simple pneumothoraces, tension, and open. Okay. Simple pneumothoraces, you see them, and it just depends on the patient. I mean, this is a stable patient without problems, breathing fine, getting what they need. There's no significant hemodynamically unstable type patient where you have to pump fluids or do something to make this better. Typically, the reason the lung collapses is that there's some type of injury to the lung itself. The lung has to heal itself, right? Not all pneumothoraces need a chest tube. Okay? Especially, 10–20% apical pneumothoraces. Give them oxygen, just watch them, serial chest x-rays in the hospital. They tend to resolve themselves and no big deal. You get an 80% lung reduction, probably going to need to. But not all of them require. Just because you don't hear lung sounds doesn't mean you need to just stick a tube in them, like I said. typically, if you're not hearing breath sounds on the pneumothoraces and stuff, it's going to be significant enough that they'll probably need a tube at some point. Simple pneumothoraces can go into what's called tension pneumothoraces. Okay? Now that's a bad problem. Okay? This is to the point to where you're getting enough air trapped inside of the chest cavity to put enough pressure on the great vessels and the lungs themselves to cause a hemodynamically unstable patient, and needs to be decompressed. Scan on the left is CAT scan showing, 30% reduction of that lung. That's a bad chest X-ray, doesn't really come across, but compared to the other side, you see how all is dark? You just don't see lung markings. It's because lungs collapsed. Occult pneumothoraces, these are kind of funny. You go and you shoot a chest X-ray, after trauma or something, and all of a sudden you're like, oh hell, there's a pneumothorax there. Is it really occult or did they miss it? It's one of those type of things where it is. A lot of times these things are missed on the initial evaluation because they're not significant enough, and you're blowing through a lot of things because there's a lot of things going on at that time, especially if they're not compromised, but especially if they are compromised and you see this, it's just not on your list to do things. Typically they're just like simple type problems. Most of them can be managed from that standpoint. Not a major issue when just kind of watching these patients with just positive pressure ventilation or CPAP, BiPAP, and what they have. It's not going to cause any major blowouts in the lungs or anything of that nature. Scoring systems, there are 10 things that you can go through and look. You never know who's going to need something. One patient may do well, another one might not. I've seen 10% pneumothoraces need a chest tube, and someone with 40% never get one. It all depends on the patient. But occult pneumothoraces, yeah, you might come across them after you're dealing with them, not a big deal, especially if the patient is stable. Tension pneumothoraces, though, these are bad problems, okay? These increase a significant amount of pressures that's just transmitted across the mediastinum that leads to a big time problem of getting blood back into the heart to pump through. If you can't get blood in the heart, you're dead, okay? You can always see these by, distended neck veins, hypersomnolent chest, no breath sounds, respiratory distress, obviously, because they just can't breathe. Patient going in shock because they can't get blood throughout things. Blood pressure is going down. Obviously, breath sounds going to be diminished on a unilateral basis. Distended neck veins, obviously, hypersomnolence. This does require immediate decompression. Okay? Typically, what you do is and these are all procedural-based type problems and what you see, and it's kind of just a cookbook of 1, 2, 3. Okay? Tension pneumothoraces, second and third intercostal space, mid-clavicular line. Put the needle in, and you'll hear all that air come rushing out. And all of a sudden, immediately, the patient's vitals come back. Pretty impressive. After the needle goes in, though, you've got to put a tube in it. Right? Here we go. Second intercostal space, mid-clavicular line, take the tube, right? There's one of the little devices. I think that's a pigtail that they're using. They got new little devices. They go in there to kind of not harm the lung any further. Obviously, when you stick a needle in there and they got a pointed edge into it, the lung rapidly expands, you can nick it, lacerate it. These little pigtails that kind of work their way in and do things, but can be very quickly decompressing somebody. I like the guy holding the guy's neck, even though he's in a neck brace. That patient probably damn near dead by the time they took a chest x-ray of that. That's impressive. I don't know if you can, I mean, that's impressive. You can see why blood came back in the heart with tension. Not as obvious, but you can still see those hearts that shifted off to the left. Open pneumothoraces. Penetrating treachery, right? Sucking wounds. Ever heard of sucking wound? That's what they do. Very interesting cases. These always need chest tube. These are also associated with the hemothoraces, right? Usually when trying to treat this, you don't want to obscure the whole wound, okay? You then still need to get pressure out of it. So you get an inclusive dressing on 3 sides of it and getting the chest tube in, but this still allows air that might be in there to kind of come out of that chest, right? You just don't pack something up in there and just say call it good, because it's not always a good thing. That can very quickly go into a tension pneumothoraces. Again, smaller pneumothoraces can be managed without intervention. You know, that kind of goes without saying. If the patient's stable, do no harm, don't kill your patient. Okay? But if chest tube is required, you know, typically suction. Have y'all ever seen chest tubes? Have you ever seen that, how they're hooked up to a little device on the floor, and that little device goes to a suction? Okay. So it's called a water seal, and that's what they're talking about there. So what the water seal allows us to do is to see, since I can't see it, maybe y'all can, but I can't see air coming out of the chest, okay? So what the water seal is there to do is to, if you see bubbles, then there's still air coming out of that lung and into the chest and is still leaking, right? So what we do is usually hook the suction, pull all the air out of the chest, help that lung expand. As that lung expands, it'll seal off its area where it's broken, basically, or tore, and it'll seal itself off to keep air from expanding back out. As you have somebody on that, you take them off suction, you keep them on water seal. If they have no bubbles, yanky panky off the chest tube and watch them scream as it comes out. Chest tubes are painful bastards coming out, especially when you have blood in there. There's a lot of scarring and fibrosing that can happen within the thorax. And again, the thorax is just a very highly innervated system that can be very painful. Persistent air leak, though, so you keep seeing bubbles for 3 days, even though you got this in there, something ain't going right, all right? Body's not healing itself. So this would actually prompt the VATS procedure to evaluate. Anybody know what VATS is? You may have heard of VATS. So it's a video-assisted thoracotomy. So basically, they don't have to make that big old incision and, you know, crank out the ribs and stuff. They just put a little assisted scope in there and go look and see what's going on. Those things have been actually great for thoracic type problems and procedures. That way people don't have long-term effects. Education of the patient with pneumothoraces, again, the rule of thumb is after 14 days they can get pressurized. You know, if they want to get taken and put somewhere. lung's not going to just spontaneously decompress. But there have been, if you ever see spontaneous pneumo, those are interesting. Those typically are skinny, tall people. People that are fat and short. Hemothorax, blood in pleural space from any source. Okay? Doesn't matter what it is, whether it's blunt or penetrating trauma. These are probably going to be more your interventional type problems in thoracic. You get blood in the chest, you got to go evaluate it. I mean, that's just the way it is. So, their definition of a massive hemothorax is 1.5 liters of blood. Okay? If you drop that much blood, you are going to be hemodynamically unstable, by the way. It's just going to happen. So, regardless of size, they need to be considered for drainage. The reason being is that blood in the thorax is very inflammatory and fibrosing. It can cause long-term problems. Okay? Can considerably delay pneumothorax healing. It can cause infections. Blood in the pleural space is just a safe haven for an empyema. And if you've ever seen an empyema, Jesus Christ, they are bad. They can cause tension pneumos. I remember when I was young, I was actually at a rotation at Southwest Medical. 22-year-old gentleman in the ICU with an empyema, IV drug abuser, right? Got tension pneumo. We stuck that tube in the drain and I remember all that pus coming out. I almost vomited on the patient. It stunk so bad. But, you know, blood in the chest wall, empyemas, they're no joke. They kill people, man. I mean, people get sick, okay? It's no joke. So typically when you see them, you're going to go in there, you're going to drain it. And typically this is going to be with the tube. You're not going to do a thoracentesis or any of that. You're actually going to put a tube in them and you can see if it continues to drain. Okay? Again, it can cause a tension. Obviously, breath sounds are going to be diminished. You can't hear through fluid as well. They're not going to be hypersomnolent, though. They're actually going to be dull. You have a thump, thump, thump to them if you have time to do that. Neck veins here aren't real good to actually have a good indicator, okay? Because they're hemodynamically unstable, you're not going to get neck distension on this, even if it causes tension. You're going to be pouring a lot of fluid in this guy. Chest decompression, you're going to put a tube in there, you're going to pull out the amount of fluid, okay? One of the reasons that you actually go in there and do a thoracotomy tube is to see how much blood actually is in there. If you pull out immediate 1.5 liters of fluid or associated to that, you're going to open the chest on this guy. You've got to go find out what the hell, why they're bleeding so bad. Okay? So this guy was probably down here on 23rd Street, down on Lincoln Boulevard, trying to get a crack. Got shot. He comes in, but you can see, like that, it's almost like that pulmonary contusion, right? You don't know if that's pulmonary contusion or hemothorax. But, like I told you in the beginning, there's not a lot of thinking to this, right? We're talking about surgeons here. This is a surgical disease. So even a surgeon could say, I'll bet you that's a hemothorax. Right? Penetrating wound, something bleeding in there. Operative intervention. So, the EAST guidelines, the EAST is, the Eastern Association of like Surgical Trauma. I think it's east.org.
you can go and look at east.org, and they've got all the studies, I mean, all this stuff that I'm talking about here. These guidelines are from, 2011, but they'll have studies that you can read if you're not too tired from reading all your medical texts. But anyway, the indications for thoracotomy and some of the guidelines that go from the evidence-based is physiology is the primary indications of surgical intervention. Persistent output, that's something to worry about. If someone produces 1.5 liters of blood in a 24-hour period or greater, that's a problem. We don't have much blood in us, but if you're dropping almost over 1 liter of blood out of your chest in a day, you need to go look at it. If you're bleeding more than 200 cc's an hour out of your tube, take that over 24 hours, that's a significant amount of blood, so you need to go look at that, okay? So, this patient, if they're doing that, is going to go get a thoracotomy, and they're going to go evaluate where that blood's coming from. They nick a pulmonary vein, they get part of the pulmonary arteries. Is the ventricle messed up? Is there something going on with just the lung itself? Something's got hit that's constantly oozing that's not going to stop until it's all out. All bleeding stops sometime. Right? Retained hemothorax and trauma. Again, the morbidity of it is the empyema, pneumonias that come from it. But fibrothorax, that's a bad one. Okay? Those people can't get their lungs re-expanded and have problems with it. Fibrosing of it won't allow the lungs to expand. You can have problems with breathing. Okay? You can also have continued problems with the lungs not wanting to re-expand. Okay? Anybody ever heard of pleurodesis? You want to talk painful. So sometimes, like cardiovascular people who have cabbages get their lungs dropped, right? Obviously, because you got to go in there and fix the heart. Sometimes they can't re-expand their lungs or have problems with it or continuously cause fluid to keep draining. Pleurodesis is where they go in there and basically take this, what's called talc powder, they'll put it all in the chest wall, inflame the hell out of it, and stick the lung to the chest wall. Painful. But stops that all from happening and going forward. But fibrothorax is kind of like that. It won't allow the lung to kind of expand itself and do things when it needs to, and sometimes you have to go in there and clear that out. Retained hemothorax and trauma. Again, reiterate, the biggest problems are empyema and pneumonia. Okay, these patients are going to have bad problems with that, especially if you have all this nutrient-enriched source of food for little bugs to go in and start growing. Okay, especially from a penetrating wound, those can be bad. Typically, the staph on our body will get in there and really take off. Video-assisted thoracotomies are very successful. When to do it, when not to do it, it depends on the patient sometimes, but I mean, you don't want to leave that in there too long. So typically they go in very quickly to assess that. Depending, and this is just looking at the data and stuff, we've had 20.4% requiring thoracotomy. Those typically are the ones that are prolonged bleeders. So people who come in, 20% of those people pretty much are going to have an open thoracotomy versus a VATS. Retained hemothorax, chest tubes, treated with VATS and not another chest tube. So, typically you get a chest tube placement, you have a hemothorax, you pull it out, you get a retained one. You're not going to put another tube in, you'll just do the video assisted thoracotomy and go look and see why. You know, you gotta, what is it, why is it, should have been gone, type thing. Usually they're, you know, again, this is associated to when to do it, when not to do it. 3 to 7 days decreases the risk of infection and conversion to an open thoracotomy. So the quicker you can do it, the better assisted problems you won't have long term from actually having to open this patient up and causing more problems, right? I mean, everybody would agree here that a small incision is greater than a bigger one, right? Intrapleural thrombotic type procedures for drainage, you know, the clots, occlusions and things. Sometimes they can squirt some stuff in there to break up clots and get it out. You know, again, this is just because they're talking about the exudative type problems of it, but this is someone with severe trauma who probably can't undergo a surgery and survive it just due to the multiple problems that they have going on at the time. To get the blood flowing or the fluid out of there, you know, they probably put in a little bit of thrombolysis, TPA into the tubes and stuff to try to get those clots taken out. The box, major issue of the whole pericardium. So this is getting into the ducts to those emergency resuscitations, right? Everything we've talked about so far has been on the periphery and so forth, but this is dealing with the most crucial aspects of the thorax, right? You hit any of that good stuff there, that's going to be a problem. Okay? Typically, you're going to see these either knife wounds or probably bullet wounds that typically come in for the trauma aspect of it, typically. The sternum and everything else really protects this area of the chest very well, as well as the spine, believe it or not. And to get from the periphery on the lateral aspects into that aspect of it takes a significant amount of trauma, and that's typically either being stabbed or shot. You can see the buckshot all in this guy's chest and belly. Not sure whether that's lung or liver kind of coming out of this guy. But the other indications of things to worry about here is what they're getting at is the thoraco-abdominal type trauma, right? Remember, our ribs extend down below the liver sits up in there. These are two concerning type things. One can involve the other, especially when you have diaphragmatic rupture or herniation. So when they're looking at penetrating wounds, especially possibility of thoraco-abdominal type things, diagnostic tests that we can easily do, an easy, quick exam is a chest x-ray, okay? If you see abdominal contents all the way up in the chest cavity, well, I mean, you pretty much understand what's going on there. The diagnostic peritoneal lavage, that's what DPL is. Basically, you know, you get down around the umbilical, cut it open, get into things, squish some fluid down in there and get the fluid back. If it's red or positive for blood, then you know you got something going on. CAT scan, with today's scanners and stuff, especially the way they can scan and the trauma bays, the way they're set, can be a quick and easy evaluation. Again, ultrasound fast, looking for fluids, getting in there, looking to see if you've got problems with fluids around, can help attest to what's going on. Laparotomy, you know, it's the times to go in and actually look at the belly and looking and seeing if something's going on, especially if you have something. People are kind of very quick to pull the trigger, especially in a hemodynamically unstable patient, to see what's going on inside the belly. Belly can be
problematic thing in trauma. But mandatory laparotomy, those are pretty much 30–40% negative most of the time. Go in like, oh, nothing really major going on anyways. Complication rate, can be up almost, I would say, to 10%. So, it's not without its misgivings. There are times that patients can do very terribly from having these complications in the surgery itself. But you just definitely don't want to miss anything. Diaphragmatic injuries and things of that nature can be missed, believe it or not. It can be very potential complications, okay? Especially if they're not very large injuries, but enough to allow potential strangulation of any viscera, okay? Bowel is obviously the most easily one to slip into a small hole. It's kind of hard for the liver to kind of go through something unless it's large, okay? Infarcted bowel and things of that nature and things that come from it are very significant. People get sick as hell and they die very quickly. It's a bad deal. But that's why you're going to see probably laparotomies performed more times than not. It's just you don't want to miss anything. Do they have abdominal trauma?
Yeah, that's next.
Oh,
2 to 4.
We'll learn all about it. Stay tuned. This is just studies that are showing, this is actually a post hoc study looking at what anything that was set up. They just went back and looked at 22 patients with no penetration. They're just showing therapeutic laparoscopy in 5 patients, observation in several. The observational group actually, had 4 right diaphragm injuries and 1 left that was missed. So, it's just going back and seeing what they want. Decreased negative laparatory rate of 33 to 20%. Is just evaluating patients and seeing what's going on with it, with certain modalities of it. But again, the basis here is that going in and looking at a patient is going to be much more impressive with doing thoracoscopies than not missing out on what's going on with the patient in severe traumas. Got a stab wound in the heart. I think this is a stab wound in the heart. Going in and just putting the figure of 8 stitch into it, and sealing off the wound of it. I don't know what the hell that is. I don't know what we're looking at. So, I don't know if you can see it or not. It's not really evident on here, and I can't see it over here of what they've got. But basically, you've got an injury that's going from the outside in here around the spleen of some sort. But I'm sure you're not going to test it on those. All right. Anybody see anything wrong with that?
Stomach shouldn't be in the left chest, right? That's a diaphragm man that's injured. The other thing about the diaphragm being injured, you know that patient can't breathe, right? Thoracotomies, the holy grail of the ER, right? So basically, you know, what are the indications going in there, especially some with acute trauma and things of that nature? You know, is this going to be something that's going to be recessive or not? Vital signs are going to be your biggest indicators and, you know, signs of life. Some guys just do it just because they like to do it, but, you know, it's a last-ditch effort. But signs of life, respiratory and motor effort, you know, do they have cardiac electricity, pupillary reactivity? You know, do they actually show that they're still the possibility of living if you can crack that chest open, okay? Timing of the arrest is also very important, you know. If someone got shot 2 hours ago, is coming in full cardiac, you know, you really gonna crack that chest? Some might, but is it gonna do anything? Probably not. You know, it's blunt trauma versus open trauma. I still haven't seen any indications to crack someone's chest with just blunt trauma, okay? You know, if someone gets a pericardial effusion or something of that from blunt trauma, you know, you just do a pericardial centesis, right? Y'all ever seen a pericardial centesis? Just going back to my cardiac days, I'll ask you this question. How do you know if you're in the pericardium or in the right ventricle taking blood out? Because, you know, the right ventricle is right there. You can stick the needle very quickly into the right ventricle. But if you get fluid out of it, how do you know you're in the pericardium versus the right ventricle? Anybody? Nobody? If you stick it in the right ventricle, the blood will clot, okay? If you're in the pericardium, the blood won't clot. So that's one way of knowing whether you're in the pericardium or not. Blood trauma. For resuscitative purposes, for after penetrating abdominal and extremity trauma, okay? So people who sustain witness penetrating thoracic trauma with less than 15 minutes of pre-hospital CPR, okay? It's an indication to crack their chest. Witness penetrating non-thoracic trauma with 5 minutes of pre-hospital. So that means, you know, going into the abdomen or something of that nature, you still having problems with the patient, you can crack that chest, okay? Witness blunt trauma, less than 5 minutes pre-hospital CPR. Probably not going to happen. But it's an indication, but I doubt they're going to do anything with that. Persistent severe post-injury hypotension. Okay? That's a big one. The tamponade, hemorrhagic, thoracic, abdominal, cervical, something that's going on that you need to take a look, or air emboli. Air emboli are a big problem. And you can get in there and suck that air out quite easily through a thoracotomy. But that's probably the one of the blunt traumas that you can see maybe, but not common in air emboli, but it can happen in pneumothoraces, okay? Obviously, we release pericardial tamponade, control cardiac hemorrhage, control intrathoracic bleeding, evacuate acid air emboli, perform open cardiac massage, just squeeze the heart, and temporarily occlude the descending thoracic aorta. That's impressive. By the way, that makes everything else ischemic below you. All right? That also comes in with the possibility of paralysis as the arteries of the spine come off the thoracic aorta.
That's the rib splitter they got in there, and doing it, and moving off the left lung and going in and looking at the heart. No, that's a figure 8 stitch to close up penetrating wound of the heart. Another stitching of the heart. It's the right ventricle. There are my references. Anybody?
Do you have any tips for our first ER rotation?
ER rotation. You know, it's gonna be, the problem with the ER is you have to see everything walks in the door. Unlike an office or a controlled environment, there you gotta see everything. There are two aspects of the ER. Typically, what they try to do in an environment is have an acute side versus non-acute side. They used to call it fast track. I don't even think they call them fast tracks anymore. I haven't seen fast tracks. But for you all, I wouldn't want to be in the fast track when learning. I'd be actually in the main ER. Trauma's great and everything. They put this in ER because that's where it comes to, but this is surgical. You won't be a part of trauma if you're in the ER, to be honest with you. That goes to the trauma team. And the trauma team is associated with all surgeons. You know, it's going to be all the basics of it. But, you know, for ER and things.
Rural ER.
Well, rural ERs, but you're going to be more putting your fingers in dikes and saying, hey, come get this patient before he dies. You know, for ER purposes and things of that nature, the bigger things are going to be the medical problems. Belly pain is a huge, huge liability. Heart, people will always tend to want to make sure they're covered on chest pains and evaluating and doing what you need to do. So I'd say abdominal pain, chest pains are the bigger type things of it. But until you get the experience of doing it, and this is where your clinical presence will have to be very sharp. You're going to have to formulate a differential diagnosis on the fly in real time, very quickly, and understand that. And in the beginning, where you're at, it's okay if you screw up. You're not responsible for it. It's very hard to do. It took me years before I became comfortable with it. But I think the bigger thing that I would kind of concentrate on as far as in the ER is knowing that if you've got a certain complaint that you're not tunnel vision down to one part, is that you fully understand the full dynamic of a differential. You just start ruling shit out. You know, that's going to apply to how you can be directed on doing blood work and what you're going to be ordering and stuff. I mean, I still have colleagues that shotgun them, whatever, just throw it out there. Someone comes in with abdominal pain, hell, they're still getting troponin. I doubt you're having a heart attack from a right lower quadrant belly pain. But some people still do it. It's just going to come full and fast-paced and stuff. And the bigger part, I would think, is that more than anything is having a significant basis of the differential diagnosis and going into something. I would say. And you can still do everything the best of your abilities and do. Like I'm in a lawsuit right now for missing a spinal abscess. It does. It had no signs of serious infection, no neurological discomforts and anything else like that, but after being in another facility for a week and stuff, he ended up dying, which I still don't see as my problem, but happens. I mean, you do what you do. So,
Yeah, someone can diagnose that as an MRI.